And I think we are recording. Let me just double check. Yes, okay. This was our fabulous playlist by our fabulous DJ. Remember, the DJ does accept tips. Hopefully, we'll see you all in a couple weeks at our next Choice Agenda webinar. This one is very focused on the US, although there are learnings that could be applied, I'm sure, globally. We're going to be talking about expanding PrEP access through community pharmacies. And I recognize this time frame is really mostly US friendly. It is not so friendly to many other time zones around the world. This is why we record our webinars. So if you're interested, you can always sign up and then just wait for the recording. So today's agenda, I'm going to turn it over to our amazing moderators in a second. I just want to give a shout out to JD and Patricia, who will be moderating this webinar. And then you'll be hearing from some really fantastic speakers, including Hannah, Sarah, Tafadzwa, Brian, and then we'll have some commentary towards the end from Maria at UNFPA. So with all of that said, I am going to stop sharing my slides, and I am going to invite both our moderators, JD and Patricia, to come to the virtual stage and get us started with your reflections. Thank you so much.
Good morning. I don't know that we decided which one of us was speaking first as a co-moderators. Trisha, would you like to begin?
You could go ahead.
Okay.
JD.
Thank you. Well, good morning, everyone, and good afternoon, good evening, good time wherever you are. This is a good time for us to come together. And also greetings to everyone who will be joining us by watching or listening to the recording. We appreciate you all for taking the time to consider these issues and all you're doing on behalf or as people living with HIV and other disabilities. So I've been involved in HIV advocacy activism since I was in my early 20s, which is over half my lifetime ago now. I've also been chronically ill probably my whole life, although I am not living with HIV. However, that wasn't really part of my consciousness in my earlier days of HIV advocacy, which was I entered, before the era of effective treatments being available in the US and much less around the world. And our focus was very much on the acute needs of ourselves, loved ones around us, and others living with HIV. Now that we're many decades into the availability of effective treatments in the United States, and thanks to the efforts of activists around the world, more access to treatments around the world, though not nearly enough, what I've seen is actually stigma in the HIV community about illness, stigma in the HIV community about disability. In the United States, in the advent of HIV activism, came around the same time as a very important wave of activism by disabled people. And in fact, a saying that I have heard a lot in the HIV community, nothing about us without us, was actually coined by disability activists. And in when these movements were happening, sometimes there was people working together, but when I later joined the movement and what I've seen since is often sort of parallel tracks of an HIV movement and disability rights or disability justice. When we say disability rights, we generally refer to a framework of rights like human rights that's based on legal strategies, that's based on opposing overt discrimination through generally legal and advocacy and policy strategies. Disability justice is a justice and liberation oriented term that was coined and defined by Black and Brown, BIPOC, mostly queer, disabled activists in the US to reflect on how many people do not benefit from legal strategies. Even if you have a legal right, it doesn't mean you get that right. And disability justice honors all bodies as worthy. All of our bodies are good, and all of our bodies both give and receive care. And so on a disability justice framework, I think it's vital that we examine, as we're doing today, are we practicing disability justice in our HIV community efforts. This is acutely of concern to me in a time where I believe that some parts of the HIV community endeavor or the HIV industry are engaging in a process of disablement, which means creating more disability. Holding massive global conferences at a time of a sustained global pandemic in which people living with HIV are 2 to 4 times as likely to have chronic and perhaps lifetime disabling chronic illness after having acute COVID infection, which is long COVID. People with HIV are 2 to 4 times more likely to have long COVID, meaning people who were exposed to COVID through their travel and their participation in the AIDS 2024 conference, which did not promote COVID mitigation strategies, are more likely to not be able to make it to the last conference. So as we talk about these issues today, I encourage us to think about who is being centered and how. I loved global conferences. I loved protesting at them. We did important work there, and I met people that I still work with to this day. However, I was always sick during and after them. Thankfully, not acutely so in a pre-COVID time. But when we think about any particular activity or strategy or tactic, how do we center people who have the most vulnerabilities to airborne pathogens? How do we center different types of access? I hope we can talk about that today. And how can we advocate for those who actually, I believe, are the most centered in these processes? Funders, policymakers in wealthy countries and others are forced to create better access for all and to integrate resources and priorities for disability justice in all that they do and all that we do. So I'll leave it at that and turn it over to my co-moderator, Patricia. And thanks again, everyone, for being here today.
Great. Thank you so much, JD, for those powerful statements. My name is Patricia Jekonai. I work with LVCT Health, and I head a HIV prevention project known as Mosaic that is introducing new HIV prevention technologies in sub-Saharan Africa. And I'm also an advocate within the HIV space, been doing that for more than a decade, and working with various populations, including persons with disabilities. And as I speak this morning or this afternoon, depending on where you are, I want to reflect on 2 key things. The first one is the last ICASA conference that I attended. And I got specifically interested in one of the sessions that had indicated that they were going to have discussions around persons with disabilities. So moved into the room when the time for that particular satellite session was starting, sat in there for more than 10 to 15 minutes, and there were no panelists, and persons with disabilities were not in the room. So we found ourselves a handful of people looking at each other and wondering why this session was in the program, and even the speakers did not turn up. And so we started talking to each other and realized how sometimes we can normalize things that really push people into the periphery. For persons with disabilities, for us in that particular meeting, it felt like either one, there was no support for them to attend, but also secondly, it was like their issue was not important. So even the panelists never turned up. And so we had a discussion on the need that if we are going to end HIV, we cannot afford to leave any population behind. Whether by virtue of the fact that we don't understand what they're going through, it is up to us to reach out, find what they're going through, and also elevate them to be able to speak about their issues. I fondly remember this young girl who walked into a facility in one of our counties in Kenya and sat in that facility from 8 a.m. in the morning and ended up leaving that facility at 4 p.m. Reason being that she could not hear. Her name was being called out severally, but she could not hear. So at the end of the day, when the facility was closing, they realized there was this young girl who's been seated here, and somebody approached her and started talking to her, and she couldn't speak. So she kept on signing, but the provider also did not understand sign language. You can imagine the frustration. So she went home because they couldn't even find a sign language interpreter. Now, that scenario makes me really be in this space and push for the agenda of persons with disabilities. And this is their experience every day. For a deaf person, it's not easy for you to tell they're deaf until they start signing. When we had COVID, we all insisted we had to have masks on. No one remembered that persons with disabilities also do lip reading for them to understand what is being communicated to them. And so communication is a major barrier. And even in the HIV space, we do materials, but we end up not translating them into the respective country's sign language, or even putting them in Braille for persons who are blind to be able to understand. I have talked to blind people, and one of their frustrations, those who are going through care and treatment, is that even our labeling on drugs is not done in Braille. So they're expected to master the drug names without having a point of reference, unless it is recorded and they have to listen to it over and over again. So as we move into this meeting, I really do hope that we can hear a lot of reflections on what can we do differently. Persons with disabilities are human too. They have feelings. They want to have sex and have it safe. And so we do have several products. We're talking about choice, but are we really presenting choice to persons with disabilities? Until we reach out and speak the language they understand and be able to understand what sort of risks are they facing, what is their vulnerability? What is the magnitude of the problem within that particular population? We will keep leaving them behind, and they interact with everyone else in the community, and we will never ever end HIV if we leave them behind. So throughout this session, I really look forward to hearing insights of how do we do this differently, because we know where there is no data, where there is no enough evidence, funding doesn't follow. And that's why there are a lot of questions around where do we get funding to program for them and what is unique. So I'm really excited and looking forward to this session and to our amazing speakers that we have today. So thank you very much. Now, having said that, I would like to take this opportunity to invite Dr. Hannah Kuper, who's from London School of Hygiene and Tropical Medicine, that is going to be our first speaker. Over to you, Hannah.
Hello, everybody. Can you hear me? And can you see my slides? Okay, so
yes, sure.
Thank you to the two moderators, and I'm going to provide a bit of a framing on disability and HIV, both what the link is and why does it matter, and that will lead into some of the later presentations. So my name is Hannah Kuper. I'm at the London School of Hygiene and Tropical Medicine, and I'm also the co-founder of the Missing Billion initiative, which is trying to use evidence to inform policy and practice. So I'm going to share a number of facts, and the first is that 16% of the world's population has a disability. So that means 1 in 6 people are disabled. So we should think about disability in everything, when we're thinking about school, when we're thinking about livelihood, but also when we're thinking about developing healthcare services. Now, we can think of disability, but disability is very, very diverse. So it includes people living in different parts of the world, men, women, older people, younger people, people living in poverty and people living in more affluence, and people with different impairment types. So the previous moderators have already talked about people with hearing impairment, with visual impairment, but also psychosocial impairments and physical impairments. So this is a very, very big group, and it's a very diverse group. But the reason why we combine them is because there are some commonalities of experience. So for instance, many people with disabilities experience poverty. They also often experience exclusion and stigma and negative attitudes. So these are very common experiences around people with disabilities. But when we start thinking about HIV, then we can realize that these things of poverty, of exclusion, of stigma are also social determinants of HIV. And so the things that are related to disability also increase the risk of people having HIV. So as an example, so overall, the risk factors for HIV are higher among people with disabilities. So they might be excluded from information and programs, for instance, much less likely to go to school, which means that they have less knowledge and information about how to protect themselves from HIV. Because of their vulnerable position in society, they may have more behavioral risk factors, such as younger age at first sex, more sexually transmitted infections, more partners, or a greater likelihood of having sex for money because of poverty. And they experience more structural determinants of HIV. So unfortunately, people with disabilities are much more likely to experience violence and poverty and reduced education. So there seems to be a very strong rationale why people living with disabilities may be more likely to acquire HIV. But on the other hand, people living with HIV may also develop different impairments that can lead to disability. So for instance, I worked on a project about HIV and hearing impairment, and we looked at different studies. And so what you're seeing here is 9 different studies from Africa among children and adults, and they pretty much all show that people living with HIV are much more likely to develop hearing impairment. And when we're thinking about hearing impairment, that might be because HIV or because the medication or because TB medication may attack the nerves and cause hearing impairment in that way. Or it could be because people with HIV are more likely to get infections, and repeated infections in the ear may cause hearing loss. So if we put all of this together, what this means is that there's a two-way relationship between disability and HIV. So on the one hand, people living with disabilities may be more likely to develop HIV, to acquire HIV, because of poverty, stigma and exclusion, because of higher sexual risk factors and violence, and because of inadequate health services and information. And at the same time, people living with HIV may develop disabilities. So that might be the direct impact of HIV, such as nerve damage, the impacts of concurrent infections like cytomegalovirus, the drug side effects of ART or other kind of ototoxic drugs, or because of the poverty, stigma, and exclusion. So what we know now is that there are many, many people with disabilities. That's 16% of the world's population, or 1.3 billion people. And people with disabilities are much more likely to acquire HIV, and HIV can also lead to disability. And what this means, if we put it all together, is that disability is very common among people living with HIV. So for instance, I was involved many years ago in a study among children in Malawi. And so what you see here is a graph. So on the one hand, the bars in green are the children with HIV, and that you can see that the children with HIV, about a third of them had hearing impairment, a third of them had physical impairments, about half of them had learning impairments or difficulties with speech. And if we compare them to the purple, which was their sibling without disabilities, you can see their sibling without HIV, you can see this enormous difference between the level of these different disabilities in children with HIV compared to children without HIV. And overall, among the HIV positive children, 1 in 3 had disabilities compared to just 7% of their siblings without HIV. And if we look more at a systematic review that was done, we can see again that among people living with HIV in sub-Saharan Africa, about 25% have physical impairments, 11% have vision impairments, 25% have hearing impairments, 25% have dementia, an even higher number have cognitive impairments, and the majority of children living with HIV have motor delays. So we see a very, very high frequency of disability among people living with HIV. Perhaps 1 in 3 or 1 in 4 people with HIV have disabilities. Now, this is a massive issue because then you have people who are living with multiple conditions, but it also means that they are multiply left behind, or it creates what we can call a double burden. So we can see among people living with HIV and disabilities, compared to those just living with HIV, they have poorer quality of life. They have poorer mental health, for instance, in terms of depression and anxiety. The children are less likely to do well at school and have much greater difficulties in forming friendships. So it's really important that people living with HIV have really good access to medication to stop these impairments, and that HIV services are inclusive of people with disabilities. Unfortunately, what we know is that people with disabilities face lots of difficulties accessing healthcare services, and that's also true when they're trying to seek HIV services. For instance, services may be inaccessible, healthcare workers may have negative attitudes. For instance, the assumption that people with HIV are asexual. There may be lack of information or information in the right formats that goes to people with disabilities. So the previous speakers talked about things not being available in sign language or Braille. There can be financial barriers because people are poor and lack of services. And so what we see across the board is that people living with disabilities are excluded from HIV services. They're less likely to be reached by education, by prevention activities. Their knowledge about the correct modes of transmission are lower. They have lower access to condoms. And highlighted in purple, they are less likely to have been tested for HIV, and they have lower adherence to HIV medication compared to people with HIV but without disabilities. Now, this is really important, these last two, because that's a direct challenge to these global HIV goals. So what are the implications for this inequity in health access? So I'm going to try and explain a slightly complicated graph. So what we see here is a graph over time, and it's for Tanzania. And it's showing a line in blue of where the current level of testing is. So at the moment, just under 85% of people living with HIV know their status. And to reach the 95% target, that blue line needs to go up and up and up to reach it by 2030. Now, we know that about a quarter of people living with HIV have disabilities, and that the people with disabilities have lower levels of testing, and so they're less likely to be aware of their status. So at the bottom, you see the grey line for people with disabilities, estimating how that number goes up, and then the red line for people without disabilities. So that means that if people with disabilities continue to have lower levels of testing, then for people without disabilities, reaching that 95% target by 2030 isn't enough. It's going to have to be much higher. It's going to have to be almost all of them so we can reach these global health targets. And if we flip it round and we start with a hypothetical group of people with HIV who don't know their status, and that reduces over time as testing goes up, at a certain point in time, the majority of people who don't know their status will be people with disabilities. So if people with disabilities continue to be left behind in testing, then we will fail to reach the 95, 95, 95 targets for testing. And this is a little bit complicated, but I've put the reference in the bottom so that people can see the table and the modeling. And we can make a similar argument for people on ART. So again, this is data for South Africa, where at the moment, just over 80% of people with HIV are on ARTs. And to reach that 95% target by 2030, we have to have almost all people without disabilities and HIV to be on treatment to compensate for the fact that we are leaving behind people with disabilities. So we're making a challenging target even more challenging. And again, if we see the numbers going down of people who are not ART, so the blue is overall, the grey is people with disabilities, and the red is people without disabilities, that this modelling shows that the majority of people who are left behind, not on treatment, will be people with disabilities. So overall, this kind of modelling shows the take home is that global HIV targets and national targets will not be achievable without inclusion of people with disabilities. So we need to think about how to make these programs more inclusive of people with disabilities. Now, what we can do is we can think of these service delivery components. So we can think from the demand side of people with disabilities, how can we improve their autonomy and awareness? It's through things like providing information in appropriate ways, in sign language, in Braille. It's about thinking about affordability. Is can we provide health insurance or health benefits for people with disabilities? In terms of supply side, we might think of human resources, so training healthcare workers about disabilities so that they can provide quality services and with good attitudes to people with disabilities. making sure that the health facilities are accessible and that rehabilitation services and assistive technologies are available. And then if we improve these points of it, then we will get a better service coverage. So that means better things like testing coverage and ART coverage for people with disabilities, and then better health status. But these service delivery programs don't come out of nowhere. So what we need to do, and that these kinds of seminars and the conferences that are mentioned are really important at tackling these systems level things. So we need to have good governance. We need to lobby together to improve the policies so that countries and programs are held to account that they need to provide services for people with disabilities. There needs to be strong leadership on this issue. And you have seen that in some countries like South Africa, where they've been really promoting inclusive health services for people with disabilities. There needs to be financing to make sure that this can be done, and data and evidence both to show what the gaps are and advocate for the need, but also the evidence in terms of what works, so that people can start to implement things that are effective. And with all of these bits together, collectively as a community, we can work to make sure that HIV programs are inclusive of people with disabilities and that their fundamental right to healthcare is met. So thank you very much for your time and attention, and I'm really excited to hear what the rest of the speakers have to say on this topic.
Thank you so much for that comprehensive yet relatively brief overview. It was really great grounding and so important to recognize not only is it the right thing to do to include people with disabilities in all we do, but we won't end AIDS unless we do it. So our next speaker, who comes to us from the Gifted Community Center in Kenya, is Sarah Mwikali.
Thank you so much. Let me try to share my screen. Okay. If you can see my screen, I need to put it in full.
Yeah, we can see them, Sarah. Just put them into slideshow.
Yeah.
Thank you.
Right. Good afternoon, good morning, everyone. My name is Sarah Mwikali. I'm from Gifted Community Center here in Nairobi, Kenya. And, you know, GCC has been here since 2019, and we've co-founded this organization with my fellow, he was my friend, but really the reason behind the formation of this organization, first of all, is because we have lived experience of disability, and there are different challenges we've experienced when growing up, from access to services, access to information and what have you. And the thought was, why can't we come up with a safe space for youth with disabilities, where we can share information, first of all, and then cascade down to other youth with disabilities. Important to note is that within disabilities and other group, we have sort of diversities. We have, age brackets. And so you find, the information that persons with disabilities can access, or rather seniors, might not be, the rate at which they could access is not the same rate adolescents and youth with disabilities can access. Yeah. So this is actually what motivated us to start this organization, and we apply to peer model. So any information coming in and capacity building cascades down to other adolescents and youth with disabilities. But really, I want to talk a lot about, GCC. You can find it on our website and what we do. So this photo, we took it under one of the, it was under HIV prevention project we were conducting in Kibera, which is an informal settlement. And a research that we conducted on access to HIV services among girls and women with invisible disabilities is what now this photo is talking about. And it was surprising, or rather even shocking to myself, that we have very many invisible disabilities, yet, they are not, they are not programmed for. When we are planning for so many things about disability and what I feel, we forget some of these disabilities, the invisible disabilities. And so our programs have been evidence-based to ensure whatever we come up, the intervention strategies are needs-based. They are customized to different types of disabilities. And so during our research, there are some issues that came up about disability and HIV. And there in our next slide, I mean, this is just strategic focus for GCC. These are part of the research that we've conducted as an organization, and you can find them on the website. But two key researches are the first one, which is a research on the uptake of SRHR, HIV prevention services among young girls and women with invisible disabilities in Kibera, and also a research on the uptake of SRHR, HIV, GBV services among adolescents and young people with disabilities in the 13 villages of Kibera. And LVCT is here, Patricia, I mean, we've been working together. So from this research, these are some of the issues that have emerged and the issues that we've been trying to, to intervene on. And one of them has always been lack of disaggregated data, because even when we started this, we were trying to look for data of persons with disabilities and we couldn't get it. We tried to look for different sites, researching, and there's no disaggregated data. And when there's no data, it means also there won't be a budget allocation on this. So adolescents and youth with disabilities, persons with disabilities are left out from, the budgeting, the budget, the government budget, and even other, stakeholders' budgets. When there's no budget, then there's also no accountability. I mean, no one will bother to understand issues on disability and HIV because it's something that is not catered for. Then another thing was intersectionality or diversity of disabilities. I mean, the interventions you will put maybe for the deaf are totally different for those who are experiencing physical disabilities, for example. You see, when a deaf is going to see a nurse or a doctor, they expect the doctor or the nurse to be speaking or understanding sign language interpreter, meaning they don't need to go with their own sign language interpreter. When they go with a sign language interpreter, they lose the confidentiality, the right to privacy when seeking medical services. So they would say, I don't want to go with a sign language interpreter. I want the nurse or the doctor to be able to understand my language. And in Kenya right now, sign language is actually a third national language. Something we're also pushing to ensure it's really, enforced in schools since, primary, secondary, university and what have you. So really we have this diversity of disabilities whose response mechanisms might not be the same across all the disabilities, and hence important not to lump sum the disabilities. Then another thing is, of course, access to HIV information. I think Dr. Hannah has talked about this, access to the services and also information. And here I'm also talking about the platforms. When do we share this HIV information? Are the platforms accessible? And do they reach adolescents and youth with disabilities early enough as their peers without disabilities? Because sometimes even the opportunities to attend conferences, that's just an example, would come much later when everyone else has received this. And so you find they are not actually part of these conferences that are organized on HIV and what have you. But really, my focus is the platforms. For the past few years, what we've been doing is we have some who are on WhatsApp platforms, but then we have majority who are not on WhatsApp platforms. And we try to through the research, come up with a way to reach those who, don't have smartphones, like text messaging. because GCC, we apply a peer-to-peer model. So when we capacity build you, when you access this information, now you're cascaded down through text messaging, and it's been working for the time being we've been doing this. Then we are talking about accessibility. I think I talked about an example of a deaf going to see a nurse or just going to health facility, but then they can't, they are not guaranteed about their privacy. And so it becomes harder for them, they don't see a need to actually go to health facilities because they are not guaranteed of their right to privacy. The same thing with going with caregivers, to these facilities. They just want that independence when seeking these services. So can we make services accessible such that I can access them independent? Of course, we have community perception of persons with disabilities about, that these negative attitudes or just ignorance, general ignorance. A parent will ask you, why do you want to go and test HIV? Is it necessary? And how can you even get HIV in the first place? So that ignorance, as well as, yeah, I think I've explained that point. The other one is basically the background of parents or caregivers who, some of them are alcoholic, and therefore they are unbothered about their children. So you find they are not accessing this or rather seeking these services. Vulnerability predisposes them to HIV. I think this Dr. Hannah has talked about, but it's something that has been coming up from the research that we've conducted and the work we've been doing. Then reporting mechanisms and processes or treatment from community level that are unclear, they are not known. I mean, majority actually don't know they exist. When do I start? For example, if I was raped, when do I start to seek services from? And then the last one is service providers' attitudes towards persons with disabilities. Some of them, or rather most of them, have little knowledge on disability and HIV. They don't know how to, to maintain the confidentiality aspect, is, with the example I just gave about the deaf. So those are some of the issues that have been coming up from the research we've conducted. And also the lip reading, Patricia mentioned it. During COVID, it was chaotic. You're being told to put on a mask, but then are we thinking about person with disability, the lip reading thing. So these are some of just the recommendations we propose, or rather that have come up from the research that we've conducted before, just deliberate research on disability and HIV. Can we have disaggregated data, even for those who are implementing different programs? Can we have disaggregated data on disability and HIV? Just intentional allocation of resources to disability and HIV, because I work in the community, I work here in Nairobi, and for organizations of persons with disability to access, for example, funding on HIV, and it's hard. Most of the time you don't know where to access these grants, where are they shared. The other thing is just collaboration with organizations of persons with disabilities. We have many organizations, or rather mainstream organizations, working on disability and HIV, but they don't involve the organizations of persons with disabilities. So you find some of the strategies even proposed really do not respond to the needs of persons with disabilities. Definitely there's need for customized and accessible channels on HIV for persons with disabilities. Accessible facilities or service delivery points. When doing this, we try to do a mapping of service delivery points. Thanks also to LVCT who are here. So we've been mapping this just to ensure we have specific delivery places where persons with disabilities can access these HIV services. And of course, the policy for home and personnel to learn sign language interpretation that we've been pushing, and thankfully it's now a national language, and hopefully our medical personnel would be able to actually learn this language. There's need for continuous awareness and education in HIV and disability from school level to community level. And the last one, customized information, education, and communication materials on HIV and disability. Thank you so much. I mean, these are just some of the policies we've been part of in the country. Yeah, so thank you so much for your time.
Thank you very much, Sarah. And just pointing out that we do have a sign language interpreter from Kenya for deaf persons who have joined us so that you also participate in this. Thank you. I'm now going to introduce Tafadzwa Maseva. Tafadzwa is from the Zimbabwe Network of Persons with Disabilities. Tafadzwa, over to you. Tafadzwa.
Tafadzwa, if you're speaking, you are still on mute.
Hello, I hope you can hear me now.
Yes, go ahead.
Thank you.
Thank you.
My name is Tafadzwa Maseva from Zimbabwe, from an organization called Zimbabwe Network for Disability, HIV and AIDS. Our mandate as an organization is to facilitate the sexual reproductive health rights of persons with disabilities. So for today, my presentation is mainly centered on the work that I have done with AVAC as an AVAC navigator. So the first thing that I did as an AVAC navigator was to do
Tafadzwa, I think we have lost you.
It looks like you might be muted.
Yes, the purpose of this handbook is to provide comprehensive information and guidance on pre-exposure prophylaxis for persons with disabilities. It aims to address the unique needs and considerations of this population, offering practical
Hi, Tafadzwa. I think we lost you again. You went back on mute. There you go.
The handbook seeks to empower persons with disabilities to make informed decisions about their sexual health and reduce their risk of acquiring HIV. The target audience. This handbook is designed for persons with disabilities who are interested in learning about PrEP as a means of HIV prevention. It is intended to be accessible to persons with a variety of disabilities, including but not limited to physical, sensory, cognitive, and intellectual disabilities. Caregivers, healthcare providers, and organizations working with persons with disabilities may also find this handbook useful, supporting and providing information to the target audience.
As a person with visual impairment, I saw the need that persons with disabilities, especially when they go to health services, there is no information on PrEP, which is in accessible formats. So under the AVAC Navigator program, I managed to design a handbook for persons with visual impairment and all other persons in large print and also in Braille. So my work as an advocate is mainly focused on the 5 A's, which is accessibility, whereby I'm pushing on the issues of translating information into Braille, print into Braille, and also conducting sign language trainings and disability management trainings to health service providers, so as to ensure that persons with disabilities are not left out. So one of the issues that we are also addressing as an organization and also as an advocate is to ensure addressing or reducing stigma and discrimination among persons with disabilities.
This stigma index report led by people living with HIV and supported by key stakeholders such as the Ministry of Health and Childcare, the National AIDS Council, UNAIDS, PEPFAR, and ZNNP+, Zimbabwe National Network for People Living with HIV and AIDS, revealed that in 2024, there was an increase in the prevalence of stigma and discrimination among people with HIV, rising from 65.5% in 2014 to 69.7%.
This reveals that persons with disabilities are not an exception. Persons with disabilities, they face major barriers. They face a lot of challenges and a lot of discrimination. Hence, their information is not clearly outlined in such researches. Hence, we are pushing the 95, 95, 95. So it's now up to us as activists, it's now up to us as advocates also to push the disability agenda. For a long time, persons with disabilities, they've been left out. Disability, it comes as an afterthought. I remember last week I was in a meeting where we were designing systems for the general populace. However, when I raised the issue of disability, they said, no, you will, as we go through with the project, we'll then pick up the issues of disability. Then it came into my mind that disability is coming as an afterthought, rather than to put disability first at design stage. We include the needs of persons with disabilities, but disability is taken like an afterthought. So I've also, through the AVAC project, managed to train health service providers in sign language and disability management. This has helped in changing the attitudes of health providers, and also through the handbook that I've designed, it has brought a deliberate awareness. Now the health service providers are now aware of the existence of persons with disabilities in their healthy facilities. Part of my work also is centered on data, in which as part of the technical working group, which is a national group that sits every quarter, we have also influenced the DHIS2, which is a district health information system, to target disability sensitive indicators on the information. As we know that most information is not disability disaggregated. As an activist, where I have pushed that in our technical working group, we see the need that disability sensitive information in all the information system is captured. You can also check an article that I worked under ADVAC that is titled "Let's Remember Persons with Disabilities," that focuses on data, that focuses on data disaggregation. Thank you.
Thank you so much for your presentation, all the work that you're doing, really showing the way of what we all should be able to do and offer to as and for disabled people. And we are now going to move to our next presenter, my comrade Brian Minalga from the Office of HIV Network Coordination, HANC. Brian, over to you.
Hi, everybody. I'm just going to put my slides up here. There they are. So, hi, good morning from Seattle. I'm Brian Minalga from HANC. And let's see, am I in the right view here? There we go. Yeah, so I'm Brian Minalga from HANC, and my goal here is to really expand the conversation, as the title on the slide implies, offering more questions than answers, really, when it comes to people with disabilities in HIV research. I do a lot of my work focused on the inclusion of underrepresented populations in HIV clinical trials, those funded by the National Institutes of Health in the United States, but global research as well. And I want to start this conversation of expanding the conversation among people with disabilities and HIV research by really coming to this question that I think is probably one of the most important ones to begin with, is how are disabilities defined? And I want to start by actually sharing a personal anecdote. I personally don't identify as a person living with a disability. I haven't considered myself a person living with a disability. But recently this year, my organization, Fred Hutchinson Cancer Center, where I work, initiated a survey, an employee survey, to be in compliance with affirmative action legislation. I think it's every 5 years they have to run this survey, and the survey asks employees at Fred Hutchinson Cancer Center to disclose whether or not they are living with a disability, and there's an option to opt out as well. And I looked at the list of conditions that are considered disabilities, and I saw that migraine is a disability considered by affirmative action regulation and legislation. And I have lived with migraine since I was 9 years old. Migraine is a condition that I've chronically gone through from the time I was 9 to the present day. And so it just, when it comes to this question of how do we define disabilities, you're looking at someone right now who apparently, according to affirmative action code, is living with a disability. And yet I myself didn't even know that I was being categorized in this way. So I think, we've already heard from the presenters so far today about what a broad category this is. And I think when it comes to inclusion and research, it's a really important question to look at how people with disabilities are defined. So I'll just continue to walk through what we mean by the scope of disability. I just did a little bit of research on this, found that, of course, we are not the first people to ask this question of how do we define people with disabilities. And so the U.S. Interagency Committee on Disability Research, apparently there is such a committee, and this agency found that there are actually 67 separate laws that define disability for federal purposes alone. So already, if you are trying to define disability and you look within the states and how these laws are defined for federal purposes, we already have 67 different definitions of disability. Here I've put some major health organizations. So the U.S. Centers for Disease Control and Prevention, or CDC, defines disability as any condition of the body or mind that makes it more difficult to do certain activities and interact with the world around them. The World Health Organization defines thus impairment in body structure or function, activity limitation, and participation restrictions in normal daily activities. The Americans with Disabilities Act, with this definition is also used within the National Institutes of Health, defines disability as physical or mental impairment that substantially limits one or more major life activities, or a history or record of such an impairment, or, this is so interesting to me, a person who is perceived by others as having such an impairment. So we really begin to see the broad definitions of disability that we're working with. And just to add to what our first speaker shared in terms of the scope of disability and people living with disabilities as a population, I found that the National Institute of Minority Health Disparities notes that 61 million people are living with disabilities in the United States. So we heard globally, but in the US, people living with disabilities account for more than 27% of the US population, or 1 in every 4 persons. I believe the global statistic we heard earlier today was 1 in 6. And the National Institutes of Health have also designated people with disabilities as a health disparities population. This is a newer designation just last year, 2023. So that was a lot of information, but in summary, I put people with disabilities in quotation marks here because it's such a broad and large category of people. So immensely broad, poorly represented in research, and also a population with urgent health needs. So that brings us to a project that we've initiated here at HANC. And it's called the Representative Studies Rubric, or the RSR. And this is my work with underrepresented populations and considering their inclusion in HIV clinical trials conducted by the DAIDS-funded networks. And this tool that we developed, it forces researchers who are designing new studies to consider the inclusion of populations in terms of age, ethnicity, gender, drug use, pregnancy, race, and sex assigned at birth. So for example, the RSR, it's a questionnaire with 12 items on it, and researchers developing new studies, they have to ask and answer these questions. Are people aged 0 to 12 included? This is one example of a question on the questionnaire. So are people aged 0 to 12 included? Yes or no? Are transgender men included? Yes or no? Are there enrollment goals set for Black participants? Yes or no? So you see, these are binary yes/no questions. And for each question that receives a no answer, the researchers are then required to provide the scientific or other rationale for not including that population. So for example, if transgender men are not included in the study, the researchers have to provide an answer as to why. But then I included this question just for the purposes of this webinar: are people with disabilities included? When we think about the broad definitions that I just walked us through, can we really answer this question the same way that we would answer the other questions included on this questionnaire, the RSR? Can we answer yes or no? And if we were to answer yes or no to are people with disabilities included, would a yes or no answer provide us with meaningful information given the broad and diverse characteristics of this category of people living with disabilities? I think probably not. So I've thought through some possible solutions to this. RSR items 11 and 12, these are the last two items on our current questionnaire, which we're using in our 4 research networks funded by the NIH. The 11th item, RSR item 11, asks about the way that we're defining gender and sex in study protocols. And so because it's kind of a longer definition, answering yes or no becomes a little bit difficult. So what we've done is we've included in this RSR item 12 a link to a guidance document. It's guidance on the use of gender inclusive HIV research practices. So we can still ask a yes or no question because we ask the researchers to go and read that guidance on how we should be applying definitions of gender and sex, and then to come back and answer the yes or no question. Are you applying the guidance correctly? And then RSR item 12 is similar. We provide a link to the NIAID HIV language guide because we're asking in this question 12, do you use stigmatizing language? Yes or no? Well, to know if you're using stigmatizing language, you can't really judge your own language. You're probably going to say, no, I'm not using stigmatizing language. But we're not asking for the subjective opinion. We're asking for the objective agreement of the language used in your study with the language used in the NIAID language guide. And so this could be a possible solution to this, so-called problem of thinking about answering a yes or no question. Maybe if there's some type of guide that could be provided on the inclusion of people with disabilities in HIV research, then you could add this as a 13th item, for example, to the RSR, are people with disabilities included according to such and such guide. So I think we would need to look, or maybe possibly even create such a guide that would help researchers consider the inclusion of people with disabilities in HIV research. A few more just considerations for expansion. RSR item 4, so back to this tool, it's considered, or it is concerned with the inclusion of people who use drugs in HIV clinical trials. And substance use disorders are also included as disabilities or categorized as disabilities, once again, in those affirmative action regulations, under which I am also categorized as a person living with a disability through my condition of migraine. And I got involved with this webinar because Jim originally asked me if I was aware of any studies in our HIV research networks that are inclusive of people with disabilities. Well, we do have this one study, HTTN 094, an HIV Prevention Trials Network, that is designed specifically for people with opioid use disorder. So, perhaps this is a study that is, if you think of it in this way, in the lens or in the framework of disability, perhaps this is a study really designed specifically for people with this specific type of disability. I will say, however, that we've done an analysis of our studies in the HIV research networks, and most of the studies regularly exclude people with substance use disorders. And our tool that we created at HANC is designed to correct this. There's a notation in most protocols that gets recycled that is kind of refers to people with substance use disorders as not good candidates for research, meaning there's a lot of bias in these studies that assumes that people with substance use disorders aren't going to show up for their appointments or will be difficult to be retained in the studies. So we're trying to correct this, but we're still finding that there may be some statistical rationale used to exclude people who may contract HIV through injection drug use, because most of the studies in our biomedical research field are designed to prevent sexual transmission of HIV. So it's this kind of paradoxical and not very helpful way of excluding a large population of people vulnerable to HIV through injection drug use. So maybe we can discuss this further in discussion. I also just wanted to note that HIV is also a disability. So when I was asked, are there studies that are inclusive of people with disabilities, I think immediately of the ACTG and impact networks and any of our studies that are including people living with HIV. But once again, it depends on how we're defining disability. If you define HIV as a disability, as many of these regulations do, then yes, most of our studies are inclusive of people with disabilities, considering HIV a disability. But furthermore, many of our studies are looking at comorbidities or health complications in people living with HIV. So, for example, a lot of our studies are looking at heart disease, HIV-associated neurocognitive disorder or HAND, inflammation, liver function, obesity, reservoir reduction, and tuberculosis in people living with HIV. So are these studies looking at disabilities among a population of people living with HIV, which is also a disability? There's an argument to be made in that regard. And this is my call to action for folks. The FDA is currently considering requiring researchers to include diversity plans in their studies. But what I think is really interesting about this document where FDA is planning this requirement is they distinguish 3 types of diversity. They talk about demographic diversity, which would include things like age, gender, and race. They include clinical characteristics as diversity, which would include comorbidities or disease etiology. And they include other characteristics as diversity, such as access to care. And so when we come to people with disabilities, depending on our definition, once again, we could consider people living with disabilities as overlapping with all 3 of the FDA's categories of diversity. So this is my call to action for folks. The FDA is currently soliciting public comment on these plans to require diversity in clinical trials. You have to submit them by the end of September. It's September 26th of this year is the last day to do so. And I think Jim is going to put a link in the chat where you can do that and submit your comments. So perhaps what we as a group could do is really think about the inclusion of people with disabilities under these categories of diversity that the FDA is planning to require researchers to submit for their studies. I would be remiss if I didn't briefly mention research ethics in this conversation about people living with disabilities in research. We have the Belmont Report, the Common Rule, the Federal Policy for the Protection of Human Participants, and these documents specify the need for the protections of quote unquote vulnerable populations. And included in that definition of vulnerable populations are pregnant people, minors, people in prison, and this category of people with diminished decision-making capacity. And what you'll see in almost every single, it should be every single research protocol, is in the inclusion criteria, willing and able to provide informed consent. So if you're someone who doesn't meet the definition of being able and willing to provide informed consent, you should not be included in the study. And this is to be in compliance with these regulations to protect vulnerable populations. And there's this large document I found as well that was issued in 2009, research involving individuals with questionable capacity to consent, points to consider. So just, additional points for consideration when we come to people with disabilities in research. A lot of folks have been thinking about this, and there are some documents for reference out there. And is this my last one? I've got 2 more slides. So we've talked a little bit about language so far today, and there is actually some policy already called the NIH Language Access Program, or LAP, which actually already requires quote, reasonable accommodations for people with limited English proficiency, end quote. However, this is rooted in the Title IV of the Civil Rights Act in the United States, which prohibits discrimination based on national origin and not disability. So you'll notice it's about limited English proficiency. So it's kind of rooted in this, this national origin prevention of discrimination based on that category and not in disability. But what about reasonable accommodations for people with disabilities that might limit their sight and or their hearing? So once again, thinking about using existing policy and including people with disabilities in the conversation. Of course, we can also ask, are these studies in compliance already, given the language that already exists? You might find that there are some gaps already, but it's something that we can all advocate for. And this is my last slide, just about further NIH policy. We already have policies and guidelines for the inclusion of women, for racial and ethnic minorities, for people in different age groups, and people from different socioeconomic backgrounds. I'm not aware, maybe there is a policy or a guideline about the necessity to include people with disabilities. And if there isn't, perhaps this is something that can be created. But once again, we have to ask, are we in compliance with what we're already supposed to be doing? I think all of this is tied, to each other. Women, racial and ethnic minorities, age, socioeconomic background, the intersectionality, with people with disabilities, as we've heard from other speakers today, is something that we all need to rally around for all of us and leave nobody behind. And as I've already mentioned, people with disabilities are designated as a health disparity population in the NIH. So I think it just furthers the urgency of really advocating for people with disabilities in HIV research. And with that, I will conclude. Thank you so much.
Thank you, Brian. Thank you, everyone, for speaking today, everyone for participating in the chat and the Q&A. Special thanks to our sign language interpreter, Eddie Ngugia. And we're now going to open up for discussion. So if I may, I'd like to start with a question that was submitted to the Q&A to give to Brian to extend your topic. What is NIH and other research bodies doing that shows the impact of community involvement and outcomes in, oh wait, it disagrees. Sorry, it disappears as I was reading it. What is NIH and other research bodies doing that shows the impact of community involvement and outcomes when it comes to standard of care and patient-centered care?
Yeah, great question about the impact of community engagement. One of the questions on the RSR is actually about the study's plans to engage community. So researchers are now also required in our DAIDS-funded networks to answer this question about what the plan is to engage community in each study. We have community advisory boards. There's lots of different ways we can think about community engagement. But what I would really just ask people on the webinar today to think about is meaningful engagement. Sometimes there's criticism of community advisory boards for, kind of being there to check a box. Like, okay, we have a CAB, we've done our job for community engagement. But I think there's a lot more to community engagement than that, really including people from the very beginning of a study concept. If you have a concept for an HIV prevention or an HIV treatment modality, what do people think about that from the concept phase, not just including people once you're ready to start enrolling people in a trial? So those are some of the things. I think the question was about measures and metrics for that. The RSR is one way to get some of that information in the study design phase. And I've seen some publications. I'll look for some that I'm aware of the impact of community engagement and put them in the chat. Thanks for the question.
Great, thank you so much for that feedback. I can see Erica Mcheka, your hand is up. And we welcome any additional questions or comments.
Yes, thanks, Patricia. First, allow me to thank all the presenters for their insightful presentation. Listening to what Hannah was presenting, you could actually see that in almost each and every indicator, people with disabilities are left behind. And yet we are talking about leaving no one behind. It's very, very interesting. And we are talking about, we are only 6 years away from 2030. And in almost each and every country, we are racing towards meeting the 2030 goal. So my question is, what should the HIV prevention advocates do? Because it looks we have a lot more to be done to ensure that we all are on the same page so that people with disabilities are not left behind when it comes. Otherwise, research has shown, data has shown, as Hannah was presenting, they have been left behind. And I'm now imagining, by the way, I work for UNAIDS. I'm in Malawi and I'm a Malawian. And I'm asking myself, if this is what data globally shows, what about in sub-Saharan Africa? In resource-constrained countries like Malawi, I should believe the figures must be appalling, must be bad. So what should HIV prevention advocates do? Where do we go for funding? Thanks, Ando.
Right. Hannah, do you want to take that?
Sure. So a lot of the data that I presented was from sub-Saharan Africa. So it does show, as you're saying, that people with disabilities are very left behind. I think what we need to do is change the narrative a little bit in two ways. So the one thing that people say is we will put basic services in place for everybody, and then we will focus on disability. And I think we need to change that narrative a bit to say from the moment of building, we will build to be disability inclusive, because that is fairer, it's respecting that population, but it also makes economic sense because it's better to build things. So for instance, it's better to, when you're starting training programs, to also train on disability than changing things afterwards to then fit in disability. I think the other thing that we need, so disability is from the start. And the other thing is I think people see HIV, or they want to see HIV as a success story. You know, there was this situation which was devastating and there was no treatments, and then there were treatments and people are living. And they want to see the end, that we're going to be living in an AIDS-free world. And so to come in and say, but, you know, many people are living with disabilities because of HIV, seems kind of depressing. And so I think we need to change that narrative from beating HIV or beating AIDS to also ensuring a good life for those people living with HIV, and that should be a part of the program. And so I would suggest for the advocates that they advocate for those things. So the one is inclusive services for all right from the start, and that those services should focus not just on beating AIDS, but on ensuring a good life for those people living with HIV.
Very well said, Hannah. I don't know if there's any other speaker wants to add a point to that. Anything that advocates can pick. I think the other thing is really the person-centered approach into care, not necessarily going in with the disease angle, but really taking care of people wholesomely and being cognizant of the unique needs that individuals have. I can see Michelle. Sorry, JD.
Yeah, I'll just add
Go ahead.
some brief thoughts. Thanks. That in order to recognize how to do better when it comes to centering disabled people, I think it's important for people who may have gone through a process of looking at internalized stigma about HIV, for example, or internalized stigma or biases about gender, to really look at how really all of us in probably across all societies since birth are really given some prejudicial understanding of bodies, of intellect, of behavior that leads to deep and pervasive stigma about disability and fear and lack of understanding, such that many of us do not even recognize ourselves as disabled because it's considered an insult. It's considered a problem. It's considered an inherent diminishment of our humanity. So when we recognize that and can look at that inside of ourselves, whether or not we identify as disabled, and then we can come to better terms with looking at program plans, making requests to funders, doing advocacy that looks at creating the ability for people to assert their own needs, their own desires, their own capacities, because there's so much diverse ways of being disabled. You know, even our best laid plans of setting up programming may leave others out. So what we need is structures that don't put things in cement and concrete to say this is what is for the disabled people. What we need is structures that do the best that we can to attend to the needs at hand, but have an openness and a recognition to the beauty and importance and power of more people coming with more needs and different needs. That's actually a bonus. That's a plus. That's how we end the epidemic, is by welcoming different needs and more needs and addressing them. And until we do that, we're still going to leave people out. And that's why it's also important to look at unrecognized and invisible disabilities, particularly in this time of so much long COVID, which people are encouraged to think about. When people do what we've heard about in the US, when people are going to their HIV providers and saying they are feeling unwell or differently impaired after COVID. And this could include being homebound. It could include, not being able to take care of one's family or home, some very major impairments. People are being told, oh, you're just aging with HIV. This is to be expected. People are being brushed off. And the fact is, there are things, although there's no cure or specific treatments for long COVID, there's things that people can do to have a higher quality of life and to address some of the symptoms or even some of the conditions in this very broad spectrum disease. So I think openness and really listening and really helping people determine and decide for themselves what will work for them is the path to really addressing better all of humanity, including the many of us who are disabled.
Great, thank you so much, JD. Michelle, we can have
Thank
Michelle
you.
Lopez and Gabriel then, yeah.
Thank you so much for acknowledging my hand, even though I wasn't a presenter, but there are many faces here that have known me for at least over 30 years. And I'm going to start saying something very basic that we tend to forget as human beings. And I learned this. I'm from the Caribbean originally. I'm from a beautiful island called Trinidad. And I was diagnosed 34 years ago, myself and my newborn baby. She made 34 June the 14th. So I celebrate a perinatally acquired HIV woman that made me a grandma. So I'm busy taking care of grandma. In a nutshell, I have to say it again. We are forgetting the basics. Who are the people in our neighborhood? It was a group of consumers living with HIV who recognized our deaf, hard of hearing, verbally impaired individuals. And we made New York State AIDS Institute create language and policy, because we speak about language a lot, and we're speaking about language from the form of, yes, looking at stigma. And I thank the work that NIH did with communities, but we cannot forget language when we speak about layman terms. What I'm saying is in my language, but is what every presenter spoke about. And it's been over again, as I said, it's been 32 years. I got involved in advocacy because I don't have the money, because I don't have the resource, because of who my identity is. I am not at decision-making tables, but I have lived to see the day I'm back at a decision-making table under NIH. And what I am saying, Brian, you have a great model. I'm looking for your model with layman terms written where NIH spells it out to these researchers. We, as members of the community, who are the people in your neighborhood? We know who makes up our community, from the disabled to the able to the making over $100,000 to the little drug user in the community to the immigrant. The list goes on. We know who they are, and NIH must be able to have language that tells researchers from the get-go of planning this study, we want to have the involvement of those who are going to be impacted by this research. When the research is done, we must have language that speaks to how this is going to impact those that participated and is reflected of this need that we found out in research, how it's going to impact their care, their access, their navigation. These are the things that the activists, some who have died, and some of the advocates are still here with me. These are the things that they discussed with us for people with AIDS. It continues. There is no way in 2024 we should be allowing any kind of research that is not inclusive and reflective of our communities. Thank you all.
Thank you, Michelle. That's a great segue. We're going to ask Gabriel to hold off for a moment because we're going to jump over to Maria Bakarudis, who has joined us from UNFPA to share some thoughts.
Thank you. What a wonderful webinar. What a wonderful community. I feel like I'm reconnecting with some people and some long lost cousins I didn't know I had. So it's nice to be together. So UNFPA is the part of the UN that does sexual and reproductive health and rights, rights and choices for all. And, we've been working on disability inclusion over a number of years, but definitely scaling it up over the years. And I mean, everything we said about HIV can also be said about the intersection between disability and maternal health, disability and, STIs, young people and what they know about sexuality, and the list goes on, pregnancy prevention, contraception, all of that stuff, right? So we really do have a lot of work to do together. And one thing I was trying to kind of take notes and, package everything that everybody was saying is that, we all have to think strategically. When Brian said, HIV is a disability, what are the pros and cons? And Hannah got into that a little bit about positioning disability and HIV in such a way, so there's intersectionality issues to consider. There's bidirectionality issues around how HIV can produce disability and disability can produce more vulnerability to HIV. And that goes for a number of other issues like obstetric fistula, for example, or, vulnerability to teen pregnancy or GBV or anything like that. So there's a lot of things to unpack around the areas of, policy, advocacy, laws, the governance, the way Hannah constructed it, and leadership, the financing. We always come back to the money and how we need to plan and have costed plans. A lot of our advocacy says put disability in, but if we don't get that costed, and how creative we have to challenge ourselves in being to get to the public and private sources of funding and financing. And then how we delivering our programs. I mean, I heard Tafadzwa very well around, having disability as an afterthought. A lot of what we're doing right now in UNFPA is looking at not only making health systems youth friendly, but also disability friendly and inclusive and all that sort of thing. Like, let's improve all our systems with that lens of leaving no one behind. And in doing so, just these kind of categories of populations and people are not even enough anymore. We're looking at reaching the furthest behind in terms of the factors that really build in that intersectionality, that you could be a young person living with HIV and have a disability and be from, a rural area and, a lesbian or whatever it is. So, we have to really challenge ourselves. I just, in my one little minute, it was to say that we have an ongoing webinar series. I'm just going to.
Oh, you muted yourself, Maria. We need you back.
Unmute. Okay,
Okay.
sorry. I just put in the chat, we have an ongoing webinar series. I work with Professor Jill Hannes Hancock from the South African Medical Research Council. I see Hannah nodding, yes. We're doing something called Breaking the Silence, and it's approach to sexuality education for young people living with disabilities, because they don't know. They have equal or less information about their bodies, how they work, disclosure issues, adherence, I mean, all that kind of stuff, when we're looking at disability and HIV. And then we have targeted programs for HIV as well. So we're doing a lot of stuff. Our next webinar is on making health facilities and health providers more disability inclusive with a very easy tool. And I know I'm way over my time, but thank you so much. And I hope we all meet again today in other forums. And Jim, I'll make sure I send you the stuff so you can share amongst the networks here. Okay, bye. And I'm a Greek American New Yorker from Queens. Okay, but living in Joburg.
Thank you so much. We'll see you on that next webinar. Is Gabriel still with us?
Okay, yeah, thank you so much. I just want to most sincerely appreciate the opportunity of participating in this webinar. Not only is it very timely, but it's also very insightful. But I just want to draw our attention to some of the challenges we face in our own environment. I'm calling from Nigeria. I cannot lay my hands on a specific data set that speaks to people with disability, people living with disability in terms of the number that are currently on treatment, the number that are living with HIV, for example, the number that are accessing PrEP, and other services along that line. And so we don't really have a national aggregated data set that speak to people with disability that can help for the purpose of advocacy. So for me, that should be the starting point. Can we have nationally disaggregated data that speaks to people with disability in terms of their vulnerability, in terms of their access, in terms of their number on treatment, and the gap that so exists? I think that should be the starting point. Number one. Number two, I also have this challenge. The challenge is that people with disability have an issue of barrier, issue of access. It is not the issue of their behavior, putting them at greater risk. And so when we are speaking, sometimes we mix all of that together, and it tends to further accentuate the discrimination and stigma that is associated with people with disability when it comes to HIV. So I would really like us to, as much as possible, make a distinction, even though it's difficult to do, between barriers, impairments, and of course, behavior that predispose people to infection, predispose people to other vulnerabilities. I just wanted to get that clarification across. Thank you, over.
Thank you so much. That's your questions are vital, and we need the answers. And distinguishing between barriers, impairments, and looking at better collection of data by and for disabled people is truly important. So thank you for that. I think it's now time to turn it over to our leader, Jim Pickett, to close us out.
Sure, I'd be happy to do that, but I think I would love to just see if folks want to go around to our speakers and moderators, and if you have one last thing or one thing you want everyone to remember, or we want to take with us as we go on to our day and our work and making sure that disability is included in everything we're doing, what would that one thing you want to share be? So I'm going to just call around. I'm going to start with Tafadzwa. Do you have one thing, a nugget to take home? And if you're talking, you're on mute.
Okay, one thing that I might just say is that disability should not come as an afterthought. When projects are being designed, we should put persons with disabilities first or among the group that is organizing. And then secondly, it is very important now as we move forward to focus on disaggregated data as a team, as activists, and as advocates. Thank you.
Thank you, Tafadzwa. Let's go to Sarah. Do you have one nugget to send folks home with today?
My nugget would be just being deliberate on providing or conducting disaggregated data of persons with disabilities, you know, the different types of disabilities and, you know, the barriers they experience while accessing HIV services. And just knowing that disabilities are different and you can't treat all disabilities the same when trying to, you know, intervene to their needs. Thank you.
Thank you. Hannah, over to you.
I would say that including people with disabilities is a necessity, it's not a luxury, and that we now know what we should be doing, we now need to start doing it. And so I encourage us all to educate ourselves, for instance, go to the UNFPA seminar with wonderful Johannes Hancock and learn how we actually now act.
Thank you, Hannah. How about you, Patricia?
Thank you very much. I think from my end is really just to call us to be intentional in ensuring that we deliberately offer, you know, services that dignify persons with disabilities, and ensuring that our services and whatever information we are providing is person-centered. They deserve to receive services that speak to their needs. And let's involve persons with disabilities. Let's not sit and define services for them. Let's talk, let's understand, let's deliver. Thank you.
Thank you. Brian Minalga.
I tell my staff this all the time, start with the end in mind. So imagine the goal that you want to achieve. Imagine, you know, the world that we want for people living with disabilities, and then work your way back from that. I talked a lot in my presentation about the definition that I think we still need to present to folks when we're advocating for the inclusion of people with disabilities. Who do we really mean? What do we really mean? And using that, you know, being rooted in the end goal to help infuse that into our definition of people living with disabilities and our path forward for their inclusion in research. Thank you.
Thank you, Brian. And for the last juicy nugget, I'm turning it over to you, JD, before I close out.
Thanks. I would just like to remind us, we don't get to pick our pandemics, unfortunately. There's no reason that any of us who know about HIV that has been with us for, you know, almost half a century now, should believe that another pandemic has ended in 4 years. This is a very specific point, but the rates of disability following COVID infections are very high. And every time you get a new COVID infection, you're at new risk of additional or new disability. So even though this is not being promoted by health authorities, and it shouldn't be our responsibility, who are already spread so thin, working on HIV and other issues, it really has to be our responsibility to recognize that COVID is now. The pandemic is now. Look at our language we use. Stop saying during the pandemic unless you're talking about now and into the future. And if you are feeling unwell months after a COVID infection or even an asymptomatic infection you didn't have, recognize you may have a chronic condition called long COVID. And there's much more we need to learn, but there are some things you can do, and you're welcome to reach out to us at Long COVID Justice, but ask the questions about what about COVID? What about long COVID? Because we know that the highest rates of long COVID are among people who are already disabled and chronically ill. We who are sick get sicker from it. It's the 4th leading cause of death in the United States right now. Let's not let this be made invisible. Thank you.
Thank you, JD. I want to thank our wonderful moderators, JD and Patricia, the excellent speakers, Hannah, Sarah, Tafadzwa, and Brian, and Maria from UNFPA for jumping in and joining us. Thank you to our co-sponsors, Biopic and Casper, and really thank you to everyone who joined us today and shared their ideas, their thoughts in the chat online. Michelle Lopez, really great to see you. It's been a minute. So as a quick follow-up, as I mentioned, everyone will get a follow-up email in the next day or so when the recording, all the slides, and our resource document are posted online. So please look for that email. It'll be coming shortly, and let's keep this conversation going, this really important conversation. And to everyone's point, do more of walking the talk than just talking the talk. We need to get busy, and there's a lot of business that we have to take care of. So with that said, thank you for sticking on with us a few minutes late. Thanks to everyone for doing that. Go and have a wonderful rest of your day or evening or tomorrow, whatever the case may be, and hope to see you online at a future TCA webinar soon. Thank you so much and take good care. Bye-bye.